Thanks to the organisers for inviting me to talk today. I'm going to just try and discuss with you where we're at with regard to managing, in particular, ICP, CPP, whether we should be sticking with the protocols, which we largely get through the Brain Trauma Foundation, or whether there's enough evidence accumulating to say that we should be doing something a little bit different to that. You're all very familiar with these concepts that we're trying to prevent secondary injury, and what we can do in the emergency department and ICU is to try and deal with some of the physiological derangements which might worsen brain outcome. But essentially what we're trying to do is preserve oxygen delivery to the brain. And obviously that depends on preserving cerebral blood flow to the brain. And one of the central tenets around this is the concept of pressure autoregulation. And we're interested in two things in particular. One is the point at which cerebral blood flow falls if perfusion pressure falls to a certain critical point. And we call this point the lower limit of autoregulation. And once we go below this, we start to reduce cerebral perfusion and we potentially get ischemia. The other concept is the fact that we can autoregulate under normal conditions and maintain cerebral blood flow at a constant level across a range of pressure. And traditionally, we've been taught in head injury that this ability to keep this flow constant across pressure may be lost, and that's associated with a worse outcome. There's an abundant literature suggesting that a low CPP is a bad thing for you, and the critical pressure that's fairly consistent in the pediatric literature is below 40. Below 40, certainly in terms of a mean pressure below 40, the outcomes are nearly always universally poor. You then get into a gradation where you'll end up with more severe brain injury or severe outcomes, and survivors tend to have a higher CPP. So that is not really in dispute. So what level of CPP should we target in children? Well, the Brain Trauma Foundation guidelines are based on a continuum, and that's based on the fact that we know that blood pressure increases normally across childhood. And one approach which was taken by the Edinburgh-Newcastle group in the UK was to try and establish CPP thresholds on the basis of normal blood pressure and normal expected ICP, although the data for that is very, very limited. As you can imagine, you don't measure ICP in healthy infants and children. They established some thresholds on that theoretical basis, and then they explored whether they were meaningful or not by looking at the amount of time that children spent below those thresholds and derived something called the pressure time index as a marker of how much time they spent below those. And they found that children who went on to do well in these different age bands didn't have very much insult below the thresholds, whereas children who did poorly spent a lot more time below these thresholds. So this sort of supported the notion that these cutoffs were associated with outcome. Another approach which was taken by a different group was to look at CPP between survivors who did well and survivors who did poorly with severe traumatic brain injury. And this was published a few years ago now. And slightly higher CPP recommendations would be formulated if you followed this approach. So we have Brain Trauma Foundation guidelines giving us one number and two studies suggesting slightly different numbers. So we're really a little unclear what to do. The other thing to remember is that the lower limit of autoregulation, the point at which cerebral blood flow falls, doesn't necessarily remain constant. It can be affected by a number of things, including patient characteristics. We know that patients who get systemic hypertension, nothing to do with traumatic brain injury, but they shift their pressure autoregulation curve to the point that their lower limit of autoregulation changes. And it may be true that we need to think a little bit more cleverly in traumatic brain injury. This is an animal model which has been repeated with different models of inducing raised intracranial pressure. And what they did was they altered blood pressure in these piglets who they induced intracranial pressure changes were in, and looked at what the lower limit of autoregulation was. And the concerning thing that they found was as intracranial pressure increased in these piglets, the lower limit of autoregulation actually changed and increased also. So this is suggesting that in patients, if this was transferable with raised intracranial pressure, we shouldn't just be applying our normal CPP thresholds, but we might even need to higher CPP thresholds. Let's just go back to the concept of autoregulation and remind you what should happen in those circumstances in a state of health. If we have intact autoregulation, a normal increase in blood pressure will result in cerebral vasoconstriction in order to keep cerebral blood flow constant. The vasoconstriction reduces cerebral blood volume, and this results in a lowering of ICP. So we get increase in blood pressure, inducing a lowering of ICP. If that is lost, we get a pressure passive situation where an increase in blood pressure increases cerebral blood volume and increases intracranial pressure. Can we test this at the bedside? And is it a binary outcome? Is it always present or absent, or does it vary with time or in different situations? And this literature is evolving quite rapidly in the last 5 years, and this is the concept of pressure reactivity index. And people realize that normally we have fluctuations in our mean arterial pressure, which are associated with fluctuations in ICP. And if you therefore look at that relationship, you may find some interesting information. This patient, every time the mean arterial pressure increases, there is a reduction in intracranial pressure. This patient has intact autoregulation. As opposed to this patient, who every time mean arterial pressure increases, there is a corresponding increase in intracranial pressure. This patient has lost cerebral autoregulation, and flow ICP is dependent on mean arterial pressure. If we plot those variables against each other and create a slope line through those, we can get a situation in the first one where we create a slope that has a negative value below 0, and this is a pressure reactivity index. And this is the context of preserved pressure reactivity, whereas in the bottom situation we have a positive slope and a value that's considerably above 0, and this is a loss of pressure reactivity. People have looked at the relationship between that value and outcome, and there's consistently a strong relationship between the pressure reactivity index and both mortality and poor neurological outcome, particularly if pressure reactivity is above 0.2. The same has been shown in children in 1 or 2 centres who have been doing this work. And then people looked beyond that and they said, well, let's look at the pressure reactivity index and plot that against the cerebral perfusion pressure within an individual patient. And what we see here is that pressure reactivity index varies with cerebral perfusion pressure, and it reaches a nadir in this patient between a cerebral perfusion pressure of sort of 75 and 85. And this has led some to suggest that this could be used to derive the optimum cerebral perfusion pressure on an individual patient basis. This is group data from a group of adults showing that if you look at the relationship between optimum cerebral perfusion pressure as judged by that plot that I just showed you and brain oxygenation, you see that there is a good agreement between the two. That is to say, if patients are spending time at a good cerebral perfusion pressure based on PRX, they have well oxygenated brains. The other thing that this data is actually showing, which is the very interesting thing, is that the optimum cerebral perfusion pressure is very different across patients, and even within the same patient across time. This patient, an adult, the optimum cerebral perfusion pressure predicted by PRX and brain oxygenation monitoring is 60 to 65. In this patient, it's much, much higher. It's 90 to 95. And so this suggests that this norm of protocolized management where you just keep CPP at one value all of the time may be quite limited in approach. It's not necessarily one size fits all. There are problems with pressure reactivity index. It's quite complex in terms of the IT requirements. It requires sort of quite clever transformations to be done. And in some patients, you don't get a nadir, so you can't work out what the optimum CPP is. A newer technique has been introduced by a collaboration between Edinburgh and Belgium. And this is using regular, normal bedside information and using some quite clever technology that I won't go into. But they have been able to show that using this thing, which may be applicable to you, for us all to use at the bedside, you can derive cerebral pressure, perfusion pressure optimum in 97% of patients, as opposed to a much lower proportion using PRX methodology. They have gone on to show that the time spent away from your optimum CPP is an indicator, an independent predictor of mortality and poor outcome, even when you take into some fairly sophisticated models like the CRASH trial prognostic model. Now, there's a whole range of these indices. Whenever you've got loads of data being spewed out at the bedside, engineers will quite easily relate one to the other. And so we have to, it's a bit of a minefield to try and work our way through this. So PRX is just one index, and some others are based on transcranial Doppler, others are based on NERS-derived values. But of the ones that are in current, that look appealing, I think the new one, the LAX, which is this perhaps more usable bedside one described by the Vanderberg group, may be of most interest. So that's CPP. What about ICP? Because again, we traditionally say less than 20, less than 25, and we adapt that across all patients. There is no doubt that intracranial pressure is bad for you after traumatic brain injury and is associated with a worse outcome. But what level should we aim for? Well, the same groups, Cambridge group in particular, have been trying to say, well, if you apply that methodology to CPP, can we apply it to ICP? And you can get similar plots, which suggests in this patient that their optimum ICP may be below 12 or 13. And in another patient here, hard to believe, but based on PRX, this patient's ICP probably only becomes a problem at 60 or 65. I think this is really stretching it a lot, but as I say, where you've got data that can be compared, groups are beginning to look at these things. I think the data for CPP is much more compelling. They did, however, show that the time spent with an ICP greater than your optimum ICP predicted by PRX was a better predictor of outcome than just a simple 20 or 25 threshold. Now, just measuring CPP and ICP in traumatic brain injury is a little analogous to us just measuring blood pressure to try and understand systemic hemodynamics. We'd laugh at that, and we know that that is not a reliable measure of adequacy of oxygen delivery to the systemic circulation. So the concept of multimodality monitoring comes up, and there is a huge range of techniques that are now available, some continuous, some intermittent, some non-invasive, some invasive, some regional, some global. And I haven't got any time to go into these in any detail. Just going to mention, well, this is a patient, I'm just showing that you can put lots and lots of probes into children and adults to monitor things. But brain tissue PO2 monitoring is the thing that's probably most widely used in adult practice. It has been clearly shown in a number of studies and in this systematic review that if you have a low brain PO2, which remember is only measuring a very, very local value in that area of tissue of the brain, is associated with both mortality and poor neurological outcome. Others have introduced the technique and have suggested that it improves outcome, but it's never been subjected to an RCT. But we do know that from this adult data that it's very common, and certainly very soon after brain injury, a large proportion of adult patients have a low PO2 value, and that it's worse in non-survivors. This group introduced the technology and suggested that they got more favorable outcomes with the technology, but as I said, not tested in an RCT. We have some pediatric data, mostly out of Cape Town, but some North American centers also. And what these show is that people typically talk about -10 being a critical threshold, -20 being where you want to keep it above 20. When they looked at 26 patients and over 3,000 hours of monitoring, they found that 92% of these children had low values and 58% had very low values. So a low brain PO2 is a common thing in pediatric head injury. And this is the interesting and worrying bit, and says why we maybe shouldn't just rely on CPP. In 25 patients, if they looked at the times when they had an ICP less than 20 and a CPP above the recommended guideline target, they still found that 32% of patients actually had a brain PO2 of less than 10. If we look at that in a different way, so this is patients with an ICP less than 20, and there's all these dots down here where their brain PO2 is less than 20, and sometimes less than 10. So there is a lot of rationale for doing more sophisticated monitoring in traumatic brain injury and not just relying on simple things like CPP, but integrating all of the inputs and the information and trying to put it all together is complex. And that's where I think we've fallen down. It still is carried out in 2 or 3 or 4 centres internationally, and they produce a lot of the papers. Hopefully that Belgian description of a bedside technology that we might all be able to integrate more easily will allow us to move forward in this area. So in conclusion, we all know that avoidance of cerebral hypoxia ischemia after TBI is critical to outcomes. And we know that ICP and CPP and markers of brain oxygenation and PRX, as I've shown you, pressure reactivity index, all carry prognostic significance. We can see physiological evidence of cerebral ischemia, both in terms of brain PO2 and PET scanning, can occur even in patients with normal ICP and CPP. So they are not in isolation sufficient in terms of monitoring. And there is accumulating evidence of the potential value for some of these other reactivity indices to be used in targeting treatments. But randomized trials are only now just beginning to be thought about. They certainly give us more information, but adding complexity to interpretation at the bedside. And it would be nice if we can design research studies to determine if a more extended neuromonitoring bundle improves clinical outcomes and cost effectiveness. But we will need cleverer IT solutions if we're going to be able to integrate that into our practice. And as always, remember that prevention is much better than cure. Thank you.